Welcome to this webinar brought to you by FUJIFILM Sonosite. This audiovisual presentation is part of the Sonosite Institute webinar series and is intended to be educational. My name is Stephanie Doniger, and I'm a pediatric emergency medicine physician. I will be speaking with you today about one of my favorite topics, the pediatric rush protocol. The objectives of this webinar will start off by reviewing the different types of shock. Then we'll discuss the uses of ultrasound for evaluating shock and distinguishing between the different types of shock. We'll incorporate ultrasound into the management of these pediatric patients. This is a true example of clinical integration of ultrasound into the management of our pediatric patients. We will apply the rush protocol to real pediatric patients. And finally, we'll discuss a proposed pediatric rush protocol. Now, I always like discussing the definition of shock so that we're all on the same page. Shock is a life-threatening condition that occurs when the body is not getting enough blood flow. And as a result, cells and organs don't get enough oxygen to function properly. In shock, physical examination findings may be misleading, particularly in pediatric patients. Overall, for shock worldwide, for all ages, there are high mortality rates, and overall, we need to do better about taking care of these patients, particularly pediatric patients in shock. We need to optimize patient outcomes and really be sure that we're making the correct diagnosis. And luckily, ultrasound can help us do all of these things. I always like reviewing the different types of shock. So to start off with, we have hypovolemic shock. Now, this is the most common in pediatric patients where there's not enough fluid. This can be seen in dehydration, such as vomiting and diarrhea, or an acute blood loss, such as in traumatic situations. Then we have distributive shock. The vessels are dilated and fluid pours into the periphery. Examples of this are septic shock, anaphylaxis, and drug exposure. Then we have obstructive shock, where there's blockage or pump failure. Now, this is obviously less common in our pediatric patients, but can be seen in situations of a pulmonary embolus, a pneumothorax, or a pericardial effusion. And finally is cardiogenic shock. It's exactly what it sounds like. It's the failure of the pump or the heart. And in pediatric patients, this is most commonly found in those with congenital heart disease, but can also be seen with inborn errors of metabolism or patients presenting with tachydysrhythmias. Side by side, you can see all of the different types of shock: hypovolemic, distributive, obstructive, and cardiogenic. Now, in adult patients, Weingart and his group developed the RUSH protocol, and this stands for Rapid Ultrasound for Shock and Hypotension. This was developed in 2008 and was really applied towards adult patients. Now, remember that in adult patients, the etiologies of shock are much more commonly cardiac etiology. So we can use the principles of the RUSH protocol, but as we go through the RUSH protocol, we'll be able to see how it is different in pediatric patients. When they initially described the RUSH protocol, they recommended using one multi-purpose probe. Now, at the time, this was the curvilinear transducer. I personally recommend using the phased array transducer, which is pictured here. It is a small footprint, which is particularly useful in pediatric patients. When you're imaging the heart, you can put the probe in between rib spaces and ideally image the heart. This can also be used for abdominal views as well as lung views. Now, this is a review of the original shock protocol that Weingart and his group introduced. Now, you'll see here that there are quite a few views. We start with the cardiac views. We have inferior vena cava. We have abdominal views, aorta, and lung views. Now, these are a lot of different views to obtain. So in order to remember the different components of the RUSH protocol, you can think of three different aspects: the pump, the tank, and the pipes. Now, the pump is easy. That's the focused cardiac ultrasound, and we can look at the squeeze of the pump. Is the heart contracting adequately? Then we can look at the tank. Now there are several components of the tank, including the inferior vena cava, the FAST, and the thoracic views. Basically, we're looking to see if we're losing fluid somewhere. The inferior vena cava, we can look at collapsibility. The FAST, we can look to see if we're losing fluid in the abdomen, or thoracic, similarly, we can look to see if we're losing fluid in the thorax. Now finally are the pipes, the aorta and the DVT. The questions that we are looking for: is there a AAA or is there a deep vein thrombosis? Now, you're looking at this lecture and you remember that this is a pediatric rush protocol lecture. Now, this is obviously less common in our pediatric patients, and I'll show you that we generally don't need to include this aspect of the rush protocol. Now, these are generally very sick medical patients, oftentimes unstable. So you need to really perform the rush protocol quickly, and you don't really have that much time to sit and remember all of the different components of the rush protocol. So that's why Weingart and his group developed this mnemonic, HIMAP. Now, again, we'll go through the different components and see how it is different in pediatric patients, but I think this is a good place to start in order to remember the different components of the rush protocol. Now we start with H, the heart. We can see here that we have the subxiphoid view of the heart, and you have a circumferential pericardial effusion. I is for inferior vena cava. We can see here the longitudinal view, and you look for respiratory variation. Morrison's, or the FAST views, you can look for fluid in the abdomen. And AAA, which was part of the traditional rush protocol. And finally, pneumothorax. So this is M mode of the lung, looking at the stratosphere sign, which is consistent with the pneumothorax. As I mentioned, in pediatric patients, we don't need to use this part, but it is easier to remember HIMAP as the mnemonic that they originally developed for the adult rush protocol. Now, I mentioned this needs to be done quickly. These are unstable medical patients. The goal is to complete this exam in less than 2 minutes, and you may actually think that that's impossible, but with experience and practice, this actually can be the case. So I encourage everyone to practice this and integrate this into the management of their pediatric patients. Now, going through the different components of HIMAP, it's good to review things that we already know and then add information on top of that. I particularly like images of markets in other countries when I travel, so here are a few examples of the heart and lung, and you can remember it that way. Basically, for the heart, you're looking for contractility of the heart. Is it squeezing? But you're also looking for effusion and tamponade. Now, in the traditional rush protocol, they describe the views of the heart as being the parasternal long axis and the apical four-chamber views. This has since changed slightly, and I would say that in pediatric patients, the preferred views traditionally could be subxiphoid and parasternal long axis views. Now, you may be familiar with this subxiphoid view, as this is the preferred view in the FAST examination. We can easily look for pericardial effusions. We can assess for asystole without interfering with compressions on the anterior chest, and we can evaluate for global function. This is considered a four-chamber view. Now, what we can see here is a still image of the heart and a video side by side. The structures that are important to note: we have liver on top, we have the right ventricle, which is the most anterior structure, we have the left ventricle, the left atrium, and the right atrium. Now, we're familiar with looking for a pericardial effusion in the FAST exam. We can also see tamponade, sonographic tamponade. Now, it is important to note that the initial rush protocol did not specifically talk about identifying tamponade. There are a few features sonographically, but this generally depends on the clinical situation of the patient. However, I feel like it's important to review in order to be familiar with the signs of tamponade in case you have a patient with tamponade. But remember, if you are identifying tamponade, you probably want to get your cardiology colleagues involved very early. especially you're not really going to do a pericardiocentesis yourself based on the results of these ultrasounds. So it's important to get cardiology involved early. As I mentioned, tamponade is generally a clinical diagnosis, but Beck's triad of muffled heart tones, hypotension, and jugular venous distension is often unreliable. On ultrasound, we can see a few features that are consistent with tamponade. We see a circumferential pericardial effusion here, all the way around the heart. You can see diastolic collapse of the right ventricle here. Other features of sonographic tamponade, we can see the inferior vena cava here and the long axis, and there's no respiratory variation. And finally, a very advanced case of tamponade is the oscillating heart. You can see the heart floating in a sea of fluid. Now, subxiphoid is a great view. It's relatively easy, but in some patients, it's difficult to obtain the subxiphoid view. Also, as part of the Rush protocol, the peristernal long axis view is important, especially when we're moving on to evaluate for contractility of the heart. For the peristernal long axis view, what I'll tell you is that for consistency of this webinar, we're going to have the indicator oriented towards the patient's left hip, or if you think of the heart as a clock, 4 o'clock. What I'll also point out is to minimize changes of settings of the machine, we're going to keep the indicator on the left side of the screen. Now, it is important to note that there are different ways that people image the heart. The view itself is the same view that the cardiologist will see, which I prefer. And again, without moving this indicator, you're having less changes of the settings of the machine itself. Now, to review the different structures of the heart, the most anterior structure is the right ventricle. Then the majority of what we see is the left ventricle here. We see the aortic outflow tract, and we see that stacked on top of the left atrium. Now we can see this in real time. You can see globally just with your eyes that this is good squeeze of the heart. Now when we're looking at the heart, there are a couple of things that you should focus on. One is the rate. Is the heart rate fast or hyperkinetic? You can often see hyperkinetic hearts in septic shock. Normal is basically normal rate, and remember this is dependent on age. And hypokinetic is less movement. You can see less movement in situations of cardiogenic shock requiring ionotropic support. But we're also going to look at squeeze. We're looking at the function of the left ventricle. Now, it is important that this is not a time for calculations or complicated calculations, that we're going to eyeball the heart. We're going to look for the squeeze. Remember, this is a rapid assessment in patients who are sick and potentially decompensating. Now, when we look at the heart, we can look globally just to see if it's squeezing, and this takes a fair amount of practice. Especially with the different age groups, the rate can often confuse you, but there are a few things that we can focus on when we're looking at the actual assessment of the heart itself or the assessment of the pump. First, we look at the left ventricle and we can see the squeeze of the septal wall to the posterior wall. So the septal wall here goes in the direction of the posterior wall of the left ventricle. Now we're also going to look at the posterior wall of the left ventricle. You can notice that it thickens when there's actual squeeze of the heart. And you also want to focus on the anterior leaflet of the mitral valve. You can see here that it's moving in the direction of the septum. Now, how good are we at estimating ejection fraction? Remember I mentioned that we're not actually doing complicated measurements or calculations. It's just this eyeball approach or visual assessment. So one study looked at emergency medicine physicians versus cardiologists, and basically they found that there was an overall agreement of 86.1%. Now, the important findings here are that in moderate dysfunction, it was really difficult to tell The emergency physicians and the cardiologists didn't agree as much, but there's much more agreement with normal and extremely poor contractility. And that's actually very important for our purposes. We really care much more about normal versus severe dysfunction. If there's just very subtle dysfunction, it's not as clinically important in these situations of shock. Now we can go over the different examples of shock just to actually reinforce this idea. This is an example of normal contractility. What you can see here again, the thickening of the posterior wall of the left ventricle. We see the movement of the anterior leaflet of the mitral valve in the direction of the septum, and we see the change in the size of the left ventricle. Here's another example. This is also a parasternal long axis view. Now the rate is very fast. This is hyperkinetic, and it can often confuse you when you're trying to evaluate for contractility. As I mentioned earlier, age is important, especially with pediatric patients. If I told you this was a newborn, the rate wouldn't be as important. It wouldn't look so abnormal. But if I told you this was a 14-year-old, this would be extremely fast for their age. So now if you ignore the actual rate itself, that was our first question. We already know it's hyperkinetic. Then we're going to focus on the contractility itself. Now, our question, is the posterior wall of the left ventricle thickening? Yes. Is the anterior leaflet of the mitral valve moving towards the septum? Yes. And is there change of the cavity of that left ventricle? Also yes. So this is actually pretty good squeeze, pretty good contractility, but it's often confounded by the fact that it's hyperkinetic. Now our next example we have here again, we have a parasternal long axis view. One thing that I can tell right away is that we have a lot more movement of the valves than we do the walls. This can also often be very confusing. If you focus on the movement of those valves, you may actually be fooled into thinking that this is adequate contraction of the heart. Now, if you forget about these valves, now you're going to look at features that we discussed earlier. The thickening of the posterior wall of the left ventricle, that's not really thickening. The change of the size of the left ventricle, that's actually not changing much either. And then if you go back to the valve, this anterior leaflet of the mitral valve is just kicking out just a bit. It's not moving very far towards the septum, so therefore this is depressed contractility. So this is fast, it's hyperkinetic in a 14-year-old, but we have poor function. Our next example here, again, we can see right away this is not the same pattern that we're used to seeing. Focusing on the posterior wall of the left ventricle that barely moves, the size of the left ventricle barely changes, and this anterior leaflet of the mitral valve kicks out just a bit but barely moves towards that septum. So this is an example of poor function. Now, this view, it's pretty difficult to tell the structures from each other, and that's often the case when you have an acutely decompensating patient who is coding. Now, what you can see right away that this is definitely not a normal heart, and that's an example of asystole. Now we've gone through the H of the high map, the heart. Now we're going to move on to the IVC. We're looking for collapsibility to see if someone is low on fluids. Now, the easiest way as a review to obtain these views are to start with the transverse view of the inferior vena cava with the indicator towards the right of the patient. Then we're going to move the indicator towards the head that we see here to obtain the longitudinal or the long axis view of the inferior vena cava. What we're looking for is changes of the size of the inferior vena cava with respiration. So with respiration, there should be variation, and this is because of changing interthoracic pressures. The way you can remember is expiration, that with expiration, the IVC will expand, and with inspiration, it will contract. Now again, you can use the phased array, which we talked about before, or we can use the curvilinear transducer, and it's really whichever one you have. Anatomically, we can look at this side by side. Indicator is towards the right of the patient. You start with the transverse view, and you can see here we have the spine Here we have the aorta and we have the inferior vena cava, and this will correspond with our ultrasound image here. The things that you'll be looking for first in transverse view are the inferior vena cava. We'll see the aorta. Then we'll see the spine with the posterior shadow. And these are the three things that you're going to be looking for. And this is particularly very important to make sure that your indicator is towards the right side of the patient and you don't change the settings on the machine. Otherwise, you may be looking at the aorta instead of the inferior vena cava. Once you obtain the transverse view, don't take your probe off of the patient. Then you'll rotate the indicator towards the head of the patient, but then you'll slightly angle towards the patient's right and slightly towards the head so that you can see the inferior vena cava as it's coursing through the diaphragm. The structures for review here, we can see liver on top, we can see the hyperechoic or bright white diaphragm, and you see the longitudinal inferior vena cava as it courses through the diaphragm into the right atrium. Now, people have described different methods of the inferior vena cava. Various studies have talked about measurements of the inferior vena cava or using the inferior vena cava to aorta ratio. Now, I would say, especially for the purposes of the Rush protocol, that I would recommend just using the Gestalt method, that you look just to see if there's collapse with inspiration. This makes ease of actually performing the Rush protocol as well as accuracy. The reason why I don't recommend using measurements for the inferior vena cava are these studies. So the initial study by Lei Chen actually seemed somewhat promising, that the inferior vena cava and aorta ratio was lower in dehydrated children. Now, the aorta was used as a correction factor since there potentially is a growth curve for the inferior vena cava. So each patient, presumably their inferior vena cava and the aorta would grow at the same rate and according to their body mass index. So that's the correction factor. But unfortunately, when they tried to use the IVC to aorta ratio, they could not validate it. So basically, the specificity was only 56%. You would do better if you just flipped a coin, unfortunately. Now, the study that actually, to me, proves that we really shouldn't be relying on these actual measurements is by Lorraine Ng, who looked at patients who had CVP monitors in place, and they looked at the IVC to aorta ratio, and it really didn't correlate. Now, it is important to note that the respiratory variation that we see in the inferior vena cava is for spontaneously breathing patients. It really is different when you have intubated patients, mechanically ventilated patients. So keep that in mind if you're assessing a patient who is already intubated and on a ventilator. So the Gestalt method, especially for the purposes of the Rush protocol, we really want to look pretty quickly to see if there's collapse or respiratory variation. Now we can see here in the longitudinal view, we see that the walls of the inferior vena cava are really touching each other. This is a situation of dehydration and the walls collapse, they almost kiss each other. Now this is in contrast to a patient who is plethoric, they're fluid overloaded. You can see the inferior vena cava here, there's barely any respiratory variation of the walls, there's barely any movement. So you can see them side by side, that we can tell the difference in the longitudinal view. Now we've looked at H, we've looked at I, now we're going to look at M. So M is for Morrison's, which is the FAST exam. This is one other part of the tank. We're looking to see if we're losing fluid in the abdomen, and we're also looking to see if we're losing fluid in the thorax. As a quick reminder, here are the traditional views of the E-FAST. Now we're going to focus on the abdominal views here. The right upper quadrant, the left upper quadrant, the suprapubic view. We've already done cardiac and we'll do lung later. So we're really going to focus on these three views: Morrison's pouch, the splenorenal view, and suprapubic. For the right upper quadrant or Morrison's pouch, this was actually developed first in the order of the FAST exam because they found in cadaver studies that this was the most dependent position in adult patients for developing fluid. What we can see here anatomically, we put the probe. This is a coronal view. You have the indicator towards the patient's head, angled back about 10 degrees, and this is what we see on the ultrasound. We can see here kidney, we can see liver, and we can see the space in between, and this is known as Morrison's pouch. Side by side, we have normal, we have the kidney here, we have liver, and we have Morrison's pouch. It's a nice clean line. And this is in contrast to a very abnormal situation where we have kidney, the tip of the liver, and a lot of fluid that extends down the inferior pole of the kidney, down the pericolic gutter. They're usually not this obvious. Now, at this view, you can answer actually two questions. You can look in the abdomen, and then if you angle your probe up towards the head slightly, we can look above the diaphragm and see if there's fluid in the thorax. You can see here, this is again Morrison's. We have liver, we have kidney, the hyperechoic diaphragm, and above the diaphragm, you can see here, this is known as the mirror image artifact. This is liver, this looks similar, but it's hazier, and that's a normal finding. Now, when we have fluid in the thorax, we have loss of that mirror image artifact. We have dark fluid here. We no longer have the mirror image artifact, but we also see something called the spine sign. The spine continues superior to the diaphragm and continues because there's fluid there acting as an acoustic window. We'll also do views of the left upper quadrant. Similarly, we'll look above the diaphragm to look to see if there's fluid above in the thorax, and we'll look in between the kidney and the spleen. It's particularly important on the left side to look around the spleen because fluid can be missed, and fluid is often not directly in between the spleen and the kidney because of ligaments. Now, after you do the right upper quadrant and left upper quadrant views is the suprapubic view. This is particularly important in children. It is important to obtain two views. Now, to start with this view, have your indicator oriented towards the patient's right side and angle slightly into the pelvis. The reason why this suprapubic view is particularly important in children, we did a study and looked at over 100 positive FAST examinations in children, and what we found was that 79% of patients had fluid in their pelvis, and this did not depend on what the lesion was. So this was regardless of whether it was a liver laceration or a splenic rupture, fluid often was in the pelvis, and this was in prepubertal children. Now we can look at this, the image, suprapubic with the indicator towards the patient's right. We have bladder here and rectum posteriorly. And what we're going to see on the image side by side, we can see the bladder looking like a rectangle, and we're looking for anechoic fluid posterior to that bladder. So now side by side, we have the transverse suprapubic view. Again, the bladder looks like a rectangle. This is normal. And an example side by side of abnormal, you can see this anechoic fluid posterior or deep to the bladder. Now, once we have this view, you want to obtain your second view of the pelvis. We rotate our indicator towards the patient's head in order to obtain the sagittal view. And this normal on the left, the bladder looks like a triangle. And side by side, we can see abnormal anechoic fluid here adjacent to the bladder. Now, what I also want to point out is that this bladder wall becomes very well defined when there's fluid next to it. Now, since pediatric patients often develop fluid in their pelvis, this is particularly important to obtain this second sagittal view. So, continuing with the high map, we've done heart, IVC, M, Morrison's for the FAST exam, A for aorta, DVT, or the pipes. But as I mentioned, this is not as common in pediatric patients. Now, it's not impossible, but it won't be so common, and I don't think it's worthwhile to spend the time in each and every patient just to pick up one in your entire career. Now finally, P, pneumothorax lung. This is another part of the tank to look if there's a pleural effusion or pneumothorax. But remember, we've already looked above the diaphragms in the right and left upper quadrants. We've looked to see if there's fluid. So we'll really just discuss pneumothorax. So pneumothorax, we're looking at the anterior chest. We're doing a quick screening and we're looking for air. We're looking for the absence of pleural sliding. Other things that we can see on the lung views, now these aren't traditionally part of the original Rush protocol, but pulmonary pathology is particularly important in pediatric patients. So we can look for other things, including pleural effusions and pulmonary edema. Now, it's always nice to remember when we're scanning that air floats to the top and fluid sinks to the bottom. So we have here, on the bottom, we have fluid. We've looked above the diaphragms at the right and left upper quadrants. Now we're going to look here at the anterior chest because air rises to the top. When I have a pediatric patient coming in who's sick, I will actually just lean down and look at the side of their chest, look to see where the most superior aspect of the curvature of their chest is, and I will put the probe right there. As a quick refresher of the technique for lung ultrasound, what we're doing is we're looking for the bat sign. This bat sign is a way of finding the pleural line. It's the ribs with the pleural line, and it's a landmark. Here we can see the ribs with a posterior shadow. Here's another rib with posterior shadow, and this is the pleural line. If you can't imagine the bat sign, here it is. This was developed by Dr. Daniel Lichtenstein in order to find that pleural line. What we're looking for is we're looking for lung sliding, and also secondary signs of lung sliding are comet tails. Side by side, this is what we're looking at. We can see the pleural line, we can see it sliding, the visceral and parietal pleura sliding across each other. And for landmark's sake, we can see rib, posterior shadow, rib, posterior shadow. Some people describe this as marching ants. We can see side by side the lack of this sliding. You can see some movement, but this movement is all together. The entire chest wall is moving together. You actually don't see that shimmering. You don't see movement or sliding of that pleural line. We can use M-mode to confirm the presence or absence of sliding. Here on the left, you can see what's called the seashore sign. If you can't picture it, we'll superimpose a seashore over it. What you can see here is the ocean, the pleural line or the waves, and that graininess of the beach. That's the seashore. That's the movement or sliding of the pleural line. Now, side by side, this is in contrast to pneumothorax, where we don't have any waves and we don't have a beach because we don't have any sliding. And that's known as the stratosphere sign and not seen in a pneumothorax. Now, the stratosphere, if you don't know what a stratosphere is, Dr. Lichtenstein described this, and he likened a pneumothorax to warplanes across the sky. So you can see these parallel lines moving across the sky, and that signifies that there's no sliding of that pleural line. Now, as a refresher, we already looked above the diaphragm to look for fluid. So we just looked for pneumothorax, but we've already done it when we've looked at the right upper quadrant and left upper quadrant. And as a quick review, we're looking for that mirror image artifact, and that means that there's no fluid in the thorax. And when we have fluid, we have absence of that mirror image artifact, and we have the spine sign. Now, moving on to a few other things that we can see as part of our lung exam. Now, notice that before we had used the linear probe for looking at lung sliding. If you have a machine that you can easily change between probes just by pushing a button, I encourage you to do so, especially in small pediatric patients. It's often difficult to see the actual pleural line in the sliding. Now, here what you can see, this is different. This is the lower frequency transducer, the phased array. The pleural line is up here. And this is an example of what we call B-lines. This B-line arises from the pleural line and it extends to the bottom of the screen. Now, I probably have a few B-lines. It's normal to have a couple of B-lines, but having more than 3 B-lines in a particular rib space is abnormal. What you can think of as a B-line, it's like a flashlight. It's shining to the bottom of the screen, and a lot of B-lines are abnormal and represent an interstitial syndrome, which can be seen with heart failure or pulmonary edema. Now that's a lot of information, but tying it all together, we have the different types of shock here. We have the different aspects of our high map, of our rush protocol. We have the pump, the tank, and the pipes. So this is the inferior vena cava, and this is lung here, and these are the pipes. Now what we can do is basically use each aspect of this rush protocol to distinguish between the different types of shock. So if we're starting with the heart here on top, now if we have deficits of contractility, we can already eliminate about half of the etiologies of shock. So the heart isn't functioning in obstructive and cardiogenic shock. Then if we move on to the lung, if we don't have lung sliding, that would signify a pneumothorax, such as an obstructive shock. Or if we have a lot of B lines, that may be cardiogenic shock. So now we can move on to cases and see how we can actually apply this rush protocol to pediatric patients. Our first case, 14-year-old female with a history of liver transplant. She came in presenting with difficulty breathing, a low-grade fever, and the previous day, interventional radiology had placed a stent. Now, she had been sitting in the emergency department waiting to be admitted upstairs and had been seen by the transplant surgeon. But as she was sitting there, she became progressively worse. She became hypotensive, tachycardic, and had altered mental status. And obviously, when I saw this patient, I was concerned. Now, admittedly, this was before I knew about the rush protocol, so I performed the ultrasounds completely out of order and finally discovered the reason why she was having acute difficulty breathing. But it's much easier if we follow this protocol of rush. Now, we're going to start off with the heart. Now, this is the parasternal long axis view. We can see here we have the left ventricle. We look at the posterior wall of the left ventricle and it thickens. It's hyperkinetic, it's fast, but it looks like it squeezes pretty appropriately. Now we'll look at the eye and high map. We're going to look at the inferior vena cava. We can see here the longitudinal inferior vena cava as it courses through the diaphragm. Now we can see here that the walls are touching each other. So this patient has less fluid than she should. She has a loss of fluid somewhere. But the question is, where is she losing fluid? So now we'll move on to Morrison's, and we can see here right away that there's a problem. So we look below the diaphragm, and there was no fluid, but once you angle up towards the diaphragm and above the diaphragm, this is towards the head, we can see all of this anechoic or dark fluid and this structure here. This is collapsed lung that is floating in that fluid. This patient has a huge pleural effusion above the diaphragm. Now, for completeness sake, we looked at the aorta and the aorta was fine. And finally, looking at the lung to see if there's pneumothorax on the left, we saw normal sliding here. You can see that pleural line sliding. On M mode, it's confirmed with seashore sign. And here back to the right side where we had seen that fluid, here's a pattern also. We don't see sliding because there's fluid. We see rib shadow, and there's all this dark anechoic fluid. So this patient had a large effusion on the right. Now, why would she have an effusion on the right? Now, remember, she had had a stent placed by interventional radiology. Unfortunately, they had accidentally nicked the diaphragm, so there was a small laceration through the diaphragm, and the patient had a large hemothorax. She was brought to the operating room, the laceration was repaired, and the patient recovered uneventfully. Now, this is much more common. That was obviously a rare presentation of a patient, but it was my first exposure to the rush protocol. This happens almost every day in especially large freestanding children's hospitals where there are a lot of oncology patients. So here we have a 6-year-old female with history of ALL. She comes in with fever, neutropenia and fatigue for 1 day. On examination, she's tired but arousable. She has warm mottled skin but delayed capillary refill. Labs were drawn appropriately, and she was immediately given cefepime while awaiting labs, and she was given 60 cc's of normal saline. Despite the fluid, her heart rate was still in the 160s, and her blood pressure was low at 80s over 40s. Now, this is important to note that all patients who come in, I don't perform a rush protocol on them. Otherwise, I would be performing way too many ultrasounds on my patients and delaying their care. Now, if they look good and I'm giving them fluid and they're responding, I don't necessarily need to do the rush protocol. However, in this case, we've already given this patient fluids, a sufficient amount of fluids, but she's still tachycardic and hypotensive. So then it becomes very useful to use the rush protocol. Now, this is not the parasternal long axis view, but this is the apical 4-chamber view. And for orientation, we have here the indicator is still on the left side of the monitor. This corresponds with the right side of the patient. This is the left side of the patient. You can see here that the right is slightly bigger than the left, and the squeeze is actually not very good. So you can see barely any movement of the walls of that left ventricle. And this is a case already we can tell right away that the heart isn't really contracting the way it should be. So moving on to the eye of the high map, we can look here at the longitudinal view of the inferior vena cava as it courses through the diaphragm. Now with respirations, we barely see any variation of those walls. So this patient, remember, has had 60 cc's per kilo of fluids. The heart isn't contracting very well, and this IVC is very full with very little respiratory variation. So this is a patient that I would stop giving fluids to. This is a patient that needs ionotropic support. Finally, we already have our answer, but we can look additionally at the lung views. You can see here, we have the pleural line. We see a fair amount of B lines that are coalescing. And that's further evidence of fluid overload and pump failure. So this is actually a really great example, especially in busy children's hospitals where it's often very difficult to admit a patient to the ICU. We can communicate with our intensivist colleagues very easily. We can show them the ultrasound images. Oftentimes, they may tell us when we call to try and admit to the intensive care unit that we should give more fluids to the patient. However, we can very easily see on this rush protocol that the heart needs ionotropic support, that we shouldn't be giving additional fluids, especially since the inferior vena cava is plethoric. So we can communicate with each other and ease transition of care and admit the patient more readily. Our next patient, we have an 8-year-old male that was transferred from an outside hospital with acute abdominal pain. They hadn't done any imaging, but because of his abdominal pain, they assumed he was probably septic from a perforated appendicitis. Luckily, at the time, we had a very astute first-year fellow in pediatric emergency medicine. He had just done his ultrasound rotation, and he was very familiar with the rush protocol and high map, so he performed the high map because he thought that this patient was septic. So I'll come back to H. Initially, we should start with the H, but I don't want to give it away. So we're going to move on to the inferior vena cava, I. We can look here at the inferior vena cava. The walls collapse more than 50%. So this patient is losing fluid somewhere and needs fluid. We can move on to P for pneumothorax or lung. We can see here we have pleural line, and we have these coalescing B lines. It looks almost solid white because there are so many B lines. So that's fluid overload. And we'll go back to the H because that's the most interesting part. We obviously should have started with the H. Now you can see here, this is a subxiphoid view. We can look at the liver on top. We have a circumferential pericardial effusion. The right ventricle collapses with contraction, and this is a case of tamponade. So this was quite surprising because this is very uncommon in pediatric patients, particularly with the presentation that this patient had. He had acute abdominal pain. So as a result of this, admittedly, the inferior vena cava you would think would be plethoric, and it was not. But as soon as they found this circumferential pericardial effusion, they admitted the patient to the pediatric intensive care unit. But before that, they called the pediatric cardiologist. They arranged for a pericardiocentesis in order to remove the fluid. The etiology was probably viral. None of the cultures grew out, and it was not a malignant effusion. But it is important to remember that this actually can happen in pediatric patients. And I wonder how many patients were actually missing pericardial effusions because we're actually just not looking. So those were all good examples of how we can apply the RUSH protocol to pediatric patients, really tell the difference between hypovolemic, distributive, obstructive, and cardiogenic shock. It's just really important to maintain a systematic approach. HIMAP is a really good mnemonic to remember the different components: heart, IVC, Morrison's for the FAST exam, A if you're doing ultrasound on an adult patient for AAA, and finally P for pneumothorax. Whatever you do, whatever protocol or approach you decide, it's really important to integrate this information with the physical examination and the patient's history into a clinically integrated approach. And hopefully we can actually see improved management of our patients in shock, particularly in the pediatric population. Now, how can we actually develop a RUSH protocol tailored to pediatric patients? In looking at the pathology that pediatric patients have, we can actually tailor this. We can change this slightly in pediatric patients, and we can use the mnemonic HIPS, HIPS, heart, IVC, pneumothorax, and suprapubic. So we're basically doing the same thing. We're looking for pneumothorax. The reason why we choose suprapubic is that suprapubic tends to be more important than Morrison's, as I mentioned earlier. Now, if that's too difficult, which often I am not a huge fan of mnemonics because I often remember the mnemonic and not what it stands for, you can think of basically what we're going to do is we're going to do the extended FAST exam, the abdominal views, the lung views, and then we're just going to add the inferior vena cava. Now, if you think about this approach, this actually makes it much easier to remember. It also makes it easier in your mind to perform this exam in less than 2 minutes. So the E-FAST with the inferior vena cava. Now the future, there's a lot of future in the pediatric RUSH protocol. It really hasn't been done before. My hope is people will apply this in pediatric patients. Now, it's also important to remember that in pediatric patients, it's not as common for them to come in hypotensive. So they may be tachycardic, they may be persistently tachycardic despite IV fluids and antipyretics. These might be the patient populations that we need to target for our pediatric RUSH protocol. But regardless, it's really important to keep in mind that this is an algorithmic approach so that you can remember the different components and that you can integrate this with all of your clinical information into a systematic approach. So it was a lot of information, but I think it's important to use the pediatric RUSH. I thank you for your attention and for watching this webinar. You can contact me by email or my Twitter handle. And also, there's a pediatric emergency and critical care ultrasound textbook that I can recommend as further applications for pediatric point of care ultrasound. Thank you very much.